Good evening, everyone. It is my proud privilege to introduce Dr. Mohammad Hasnain Kaisar, who is an experienced consultant physician and nephrologist at Dr. Hasnain's Medicare Center Private Limited in Patna. With over 13 years of experience as a government medical officer, Dr. Hasnain specializes in nephrology, endocrinology, and diabetes management, additional expertise in cardiology and endoscopy. He earned his MBBS from Darbhanga Medical College and Hospital, followed by an MD in medicine from Delhi University and a DNB in nephrology from National Board of Examinations, New Delhi. Dr. Hasnain has also completed postgraduate diplomas in diabetes management from Middlesex University, London, and in cardiology from Johns Hopkins University and the Royal College of Physicians in London. As a speaker, Dr. Hasnain has presented on topics such as diabetes management, diabetes nephropathy, and hepatitis. His sessions have been hosted by organizations like Sanofi and Boehringer Ingelheim. A member of the Indian Medical Association (IMA) in Bihar, he actively participates in advancing health care in his community. Dr. Hasnain's dedication to comprehensive patient care, combined with his pursuit of medical knowledge, makes him a respected figure in Patna medical community. Today, Dr. Hasnain will be talking about diabetes and kidney. Over to you, Dr. Hasnain.
Thank you very much, sir, Dr. Shariq, sir, to introduce me. Uh, and all of you person who are just joining the diabetes and the chronic disease. So, as we are knowing that the diabetes in India is very prevalent, and it is large populations are involved not only in India, it is worldwide. The prevalence of diabetes is 9.6% among the adults and age 20 and above. And diabetes in India is second highest in the world, next to the China. And over 53.1% of the adults living with the diabetes are undiagnosed. And India, 1 in 11 adults is living with the diabetes. So diabetes is a very chronic disease among the different members of a family in India as well as the all over the world. It is not only affecting the different part of the world, but also affecting the kidney, which is one of the most important and vital organs of the body is there. So in the later sessions, we will discuss the diabetes, how the diabetes affect the kidney of the person who is having a diabetes for the long duration. So says discuss the data of the different person here. So how it is chronic in India and affecting the different populations community in all over the India. So large amount of the investing and medicine are going on. So it is very important. If the diabetes is not treated properly, if the diabetes is not controlled properly, it will definitely affect our kidney, and it becomes after a certain time become chronic kidney disease. The rise in the number of the people with the diabetes, type 2 diabetes, in driven by a complex interplay of socio-economic and demographic, environmental, and genetic factors. So diabetes and CKD, it's very important how it is involving. So hyperglycemia, if there is a high rise of the blood sugar in the body, it leads to the affect the glomerulus as well as proximal tubules. As the glomerulus is affected, there is an increase in the angiotensin system, activation of the angiotensin system, and there is a rise of ACE enzymes. And this leads to the activation of angiotensin 2, and there is a definitely the pressure and filtration pressure is rises, and albuminuria is there. There is an injury in the glomerular tissues, glomerular cells, and there is a overload there, injury is there, and there is a definitely due to high pressure, hyperinflations, and there is a hyperinfiltration, there is a glomerular injury, and albuminuria is ultimately caused. Early it is in the microalbuminuria, later it has become the overt. So as in the see that proximal tubule, mRNA, renin is mRNA mediated renin is activated and leads to angiotensin activations. This leads to rise of angiotensin 2, and which causes increase in tubular, which leads to increase in the blood pressure, hypertension, and other factor which leads to the development of hypertensions. So in diabetic patients who are suffering, having the diabetes for the long durations, they are not only having the hyperglycemic effect, but also having a increase in the sodium absorption leads to the hypertension is there, which ultimately affecting our kidney and other vital organs, cardiovascular system is too. Another, if there is a proximal tubule growth is there, increase in the SGL2 secretions, increase in examinal reabsorption of the sodium is there, decrease in the sodium, decrease in the TGF factor and RA, a single nephron GFR is there, and progression of ultimately all this factor leads to the development of CKD. So chronic kidney disease involves the progressive, irreversible loss of kidney function and defined as either as presence of kidney damage, pathological abnormalities, and glomerular filtration rate GFR and less than 60 ml per minute for the 3 months or longer. This is the definition of chronic kidney disease. As we know that diabetes not only affecting the kidney, there is a 44% other causes there, and high blood pressure is 29% is there, and 18.4% other, and glomerular disease leads to 7%, and 1.6 is the polycystic kidney disease, which leads to the chronic kidney disease, the main factor. We see that among this chart, what we find, the our populations are affected of the CKD is mainly affected by the diabetes. As you know, that classification CKD, there is a classification and screening of CKD is there. As we know that CKD is classified based on cows and scows, GFR, and albuminuria. Mainly, we are affecting the glomerular filtrations as well as albuminuria is always involving. When we categorize G1, according to GFR changes, milliliter per minute, 1.73 meter square, descriptions and the range is there. G1 is the normal high. It is GFR is more than equal to mildly decrease, 60 to 90 is there. When mild to moderately decrease, G3A is categorized, and when GFR is 45 to 59, and G3B is categorized as moderate to severely decrease, and it is 30 to 44, and G4 is severely decreased, 15 to 29, and G5 is kidney failure less than 5. So according to the albuminuria categories, one thing I would like to clear here, the chronic kidney disease is not only classified on the basis of eGFR. Other portion is also, when the particularly diabetes is concerned, it is albuminuria is also there. So we categorize the diabetic kidney disease according to the albuminuria mainly, A1, A2, and A3. What will happen in the A1? Normal to mildly decrease, less than 30 milligram per gram, and less than 3 milligram per millimoles. Screen is 1, screen 1 is 2, it is yellow screen is there. So it is under the threat, and treat the patient, and not when the treat to refer is there, treat and refer to the next is there. So when A2 is there, moderately decreased, 20 to 29 milligram per gram, 3 to 29 milligram per millimole is there, and A3 is severely increased, more than 3 milligram per gram, and more than equal to 30 milligram per millimole. So it is very A4 is in this categories. What we see, there is a text with A4 protein is always is there. So very important. So in diabetic patients, not only we are looking on the therapeutic significance strategy of diabetes is very important. So early initiation of combination therapy is an approach to achieve the glycemic goal earlier and delay the deteriorations of the glycemic control with possible better and preservation of beta cell functions. As normal medication therapy, these are used with diet and exercise to control high blood sugar in adult with type 2 diabetes. They are DPP-4 inhibitors and GLP-1 receptor analogs like glucagon, like peptides 1 receptor agonist regulates and restore the incretin functions. So here, SGL2 inhibitors, DP4 inhibitor with fixed dose combination is suitable option for the Indian type 2 diabetes patients for the following reasons. It is a safer, rapid, and sustained glycemic control, improves both insulin resistance and the beta cell function, helps reduce the body weight and blood pressure, extra glycemic benefits, reduces the pill burden, adherence to the compliances, improve overall cost effects. So what we see here, so in later question answer portions, we will see how the SGL2 and DP4 inhibitors are good for the diabetes, always helping in reducing the and controlling the delaying the progression of CKD. In this another slides, SGL2 inhibitors and DP4 inhibitors in diabetes management is there. So dapagliflozin in combination with the sitagliptins was well tolerated, lead to clinically meaningful reduction in the glycemic parameters and body weight that were sustained through the 48 weeks of the treatments. And this graph this shows that there is HbA1c adjusted mean changes from the baselines. They are after 4 weeks, 8 weeks, 12 weeks treatments. We see that there is a complication of there is a compliance of the good results here. So in this slide also the same results is there. So what the slide here show that there is a SGL2 inhibitors and DP4 inhibitors synergistic combinations, because we'll discuss later on. This is a synergistic combination with the, because not only helping in reducing the weight, not only helping the glycemic control, but it's also fruitful in delaying the CKD and delaying the fibrosis of tubulointerstitial tissues. And the benefits of SGLT2 inhibitor, what we see here, is depicted in this slide here. And SGLT2 inhibitor is in the liver. There is a NEFA utilizations, increase hepatic glucose output, decrease ketogenesis, decreases steatosis, and there is a glucosuria and natriuresis. Very important, natriuresis. There is a loss of the sodium from the urine, leads to the decrease in the blood pressure. It will decreases the filtration pressure and delaying the progression of CKD here. So cardiovascular, decrease atrial stiffness, decrease plasma volume, and decrease in the blood pressure, improved endothelial function, and decrease in the congestive heart failure. That's why DP4 inhibitor now, without any hesitation, the cardiologists are using dapagliflozin as a treatment guideline for the congestive heart failure patients. In the lipids, in lipids concentration, they increase in the lipolysis, NEFA increases uptake, and there is a decrease in the fat mass. Definitely, when we are using the SGLT2 inhibitors, there is a definitely reduction of 4 to 5 kg of weight. So in kidney, tubulo-glomerular feedback restoration is there. There is decrease in oxidative stress, decrease in the fibrosis, and increase in diuresis and uricosiria is there. So this is a beneficial effect of SGLT inhibitors, not only over the kidney, but is also over the liver as well as cardiovascular part. Evidence-based study, dose adjustment in CKD is there. So based on chronic kidney disease, HbA1c reduction applicable as above. SGLT inhibitor, SGLT2 inhibitors and their combinations can only be used when EGFR 45 milliliter per minute per meter square. SGLT inhibitor with the positive kidney outcome in cohort should be preferred in kidney disease, and DPP4 inhibitor with the proven kidney safety and should be preferred in the kidney disease. So this is very important slides here. So dapagliflozin 10 milligram per day in initiation not recommended with the EGFR less than 25 and may continue if tolerated for the kidney and CV benefits until dialysis. And the maximum dose of the sitagliptin is 50 milligram daily, and maximum 25 milligram once daily if the patient is EGFR less. So what we see that glucose lowering efficacy is reduced with the SGL2 as EGFR decline, but kidney and cardiovascular benefits are preserved. Dapagliflozin is approved for the use at 10 milligram once daily with EGFR for 25 to 45. So a holistic approach of patients with the diabetics and the chronic kidney disease. So you know that as we know that with the combined approach of decreasing the diabetes with the healthy diets, physical activity, cessation of smoking, weight management, all this holistic approach with the use of SGLT2 inhibitors, dapagliflozins, and other hypoglycemic drug leads to the combined development of the control of the diabetes as well as the development of the delaying the progression of the CKD. So here, with the first line drugs, SGLT2 inhibitor should be there. Metformin is, as we are knowing that metformin is as usual always. But if GFR is less than 30, we are not using the metformin. In the same way, if the GFR is less than 20, we are not using the SGLT2 inhibitor, particularly the dapagliflozin. So RAS inhibitors at the maximum tolerated dose if hypertension is there. So and non-steroidal MRA if ACR is more than equal to 30 milligram per grams and normal potassium is there, and dihydropyrimidine CCBs and diuretics if needed to activate the individual BP target. So in the CKD, not only we are going to use the SGLT2 tight glycemic control, as well as the drugs which are delaying the progression of the CKD, like CCB inhibitors, cilnidipine is the very good molecules, and the potassium non-steroidal MRA is also very good option is there. So what we see here, antiplatelet agents we are using to decrease the cardiovascular side effects, like antiplatelet agent for clinical atherosclerotic vascular disease, estimabib and PCSK9 if isopropanol ethanol if indicated based on the SCVD risk and lipids. So what we see that the regular risk factor assessment every 3 to 6 months is very important. So the management of diabetes, tight control of the hyperglycemia with the use of these molecules definitely delay the progression of the CKD. Thank you very much.
Excellent talk, Dr. Hasnain. You explained most of the things nicely, but there are some questions to make the topic very clear to the audience. It's a common question which most of the individuals, people with diabetes ask. So, what are the early signs and symptoms of CKD in individuals with diabetes?
So early sign at microalbuminuria, like this is the MAC, it between the 30 to 300 milligram per 24 hour, and presence of a small amount of albumin in the urine, and reduced glomerular filtrations rate (EGFR) less than 60, and the symptoms usually the patient say these are fatigues, weakness, swelling the lips, feet, ankle, hands, increased thirst. Sometimes there is a change in the metabolic state. If the patient is long duration of diabetes, we definitely suspect, and we used to in the 3 to 6 months, as I said in the earlier slides, always there is a in the 6 months or once in a year, microalbuminuria should must be go for the test for the microalbuminuria. It is simple test, and it is easily available all over the part of the country. So if the duration is more than 10 years, poor glycemic control, HbA1c is more than 9, there is a hypertension to patients, and a family history of CKD, obesity is there, if there is a age more than 60, these are the early signs. Actually, these are the early risk factor, and the patients having diabetes not control hyperglycemia, there is a high chance of there is a early development of the CKD. So without any hesitation, a doctor who is looking after these patients, go for the simple test, microalbumin in a urine. It can be easily diagnosed.
Right, thank you. So, people, how can people manage diabetes, and can diabetes management help prevent or slow down the progression of CKD?
This is a very good question, sir. Usually, that say as we discussed in the slide, there is a 44% responsible diabetes is responsible for the development of the CKG, and second one is the hypertension, which is about 24%. So first of all, we have to control the sugar in a very tightful manner. Otherwise, you ultimately develop into CKD. We see in our clinical practices. So we should have to maintain our HbA1c less than 7% and monitor blood glucose regularly, adjust medication and insulin dose as needed. And if there is a hypertension, to control the hypertension, our target blood pressure is less than 130 by 80 mm of Hg. And whenever there is a if the patient is having hypertension, we immediately start ARBs or ACE inhibitors. And otherwise, if the patient is not having hypertension, there is a microalbuminuria might be there, we should start low dose of ACE inhibitors or ARB. Renal protective measure. The renal protective measure. So just we have to said that we in the low dose like ACE inhibitors, ARB should be started immediately. And there is a monitoring of a USCR, spot urinary albumin creatinine ratios must be there, and reduction in the sodium is very important. It should be less than 2300 milligram per day. Either table salt, we should extra salt which are using in our salads and different achar, papar, and this kind of things there. We should have to avoid them. So and lifestyle is very important. I very say that if there is a you are not having a good lifestyle, whatever the medications, whatever the prophylactic treatment you are taking, it is not useful. It will not delay the development of this CKD. You should have to be a healthy lifestyles. So you have to control your weight, you have a regular exercises, and you have to just I say smoke you have to smoke cessate the smoking, stop your smoking, limit alcohol consumptions. And these are the very important aspects for the development. Sometimes we are using the when we are prescribing the oral hypoglycemic drugs like SGLT2 should be added earlier, like IMPA, CANA, DAPA, angiotensin beta blocker should be started as a the good for the controlling and delaying the CKD. And regular monitoring of what I said, HbA1c, blood pressure, annual serum creatine, EGFR should be done. USCR is very important every 6 to 12 months. And the lipid profile, electrolyte testing is very important. So lipid profile is also checked on a regular basis.
So, you mentioned about albuminuria nicely. So, apart from albuminuria, what are the recommended screenings and tests for detecting CKD in individuals with diabetes?
Yeah, this is very important. In the CKD patient, serum creatine EGFR is very also important. In CKD patient, EGFR is very important, like that. And sometimes creatinine albumin ratio, this is very important. It becomes very important at times. So EGFR, UACR, These are the lipid profiles, electrolyte panel. This is the annual screening methods there.
As you told, the initial stage is that of renal hyperfiltration. So, can you explain the concept of renal hyperfiltration a bit more and its role in the early stages of diabetic kidney disease?
That's when the patient is increased hyperfiltration refers to an renal hyperfiltration refers to an increased filtration rate above the normal level. Usually, we see that is normal in our community. What it is about 120 is the maximum aspect. But initially, when there is a starting of the development of the CKG, there is a EGFR is above the 120 ml per minute. So it is very awesome. It doesn't mean that our kidney is more healthy. No, it is alarming sign here. So this occurrence when the kidney compensates for the insulin resistance and the hyperglycemia by increasing the blood flow and the filtration. Is this times there is an insulin resistance and hyperglycemia is responsible for the increasing the blood flow as well as the filtration, and this is called renal hyperfiltration. In the early, it is the role in it is the early sign of the diabetic kidney disease. So in the early stages of DKD, renal hypertension play a pivotal role, increase the plasma reabsorption, increase the renal hypertension, intrarenal hypertension is there, glomerular injury is there, albuminuria is the important factor initially, and there is these are the main importation. So hyperinfiltration leads to the increased glucose absorptions and excavation of hyperglycemia is there, elevated blood flow and filtration pressure damage the renal microvasculature, as well as glomerular injury. Hyperfiltration causes mechanical stress, leading to the glomerular damage and inflammation is there. So increased filtration and damage to the glomerular barrier allow albumin to leak into the urine. This is the very important. Hyperglycemia, increased renal blood flow, and the vasodilatations. These all elevated angiotensin 2 and the transforming growth factor beta. These are the beta, TGF beta. These are the inflammatory molecules. It rises in the hyperinflation.
Right. So mention about inflammation as well. So can you explain specific renal benefits of SGLT2 inhibitors and how they prevent CKD in diabetes?
Sorry, once you repeat.
SGLT2s have come in a big way in diabetes management as well as diabetes kidney disease. So can you explain specific renal benefits of SGLT2 inhibitors and how they prevent CKD
Please,
in
sir.
diabetes?
Yeah, sure, sir. SGLT2 inhibitor works by inhibiting the SGLT2 receptor in the kidney and reducing the glucose reabsorptions, increasing the glucose excretion in the urine, and lowering the blood glucose level. And what are the benefits by the SGLT2 inhibitors here? Improved glycemic controls, weight loss due to increased glucose excretions, blood spleen reduction, blood glucose, blood pressure reductions. As we saw that there is a natriuresis in the slides. There is a reduction in the blood pressure of the cardiovascular because it increases the lipolysis, decreases the sodium plasma. So these all the beneficial aspect ultimately leads to the benefit in this progression of CKD reduction, and there is a reduction in the albuminuria, slower decline in the glomerular, decreases the renal fibrosis, and improve the renal blood flow. These are all the parameters which has been proven in the different trials like empagliflozin, EMPA, outcomes, canvas trials. This all has been explained.
So, are there any specific patient populations that may benefit more from the combination therapy of SGLT2 inhibitors and DPP4 inhibitors in terms of CKD prevention?
Yeah, definitely.
SGLT2 and DPP4 combination.
You're talking about the. Sorry, once you repeat the question, sir.
So we can use SGLT2 inhibitors alone, but we can use them also in combination with DPP4 inhibitors, right?
Definitely, sir. Yeah. I get it. So
So any
definitely.
specific patient population where you would like to use the combination?
Definitely, sir. Both of them having a synergetic effect, actually, sir. So those persons who are using the only the SGLT inhibitor, if we are adding the like sitagliptin or linagliptin kind of molecule with these combinations, that is having the synergetic benefits in the patients, and they are tightly control the blood glucose. Not only those who are not controlled by the SGLT2, metformin, other baskets, the anti-diabetic molecule from the diabetic baskets. So if you are adding these SGLT inhibitors, it will help in controlling the CKG. helps in controlling the hyperglycemia and ultimately affect the effect on the EGFR as well as the microalbuminuria, as well as micro as well as macro both, and there is a body mass index is also decreasing. These kind of the very beneficial effect we are using together here.
Right. In this regard, there's another question which is linked to the first question. Are there
Okay.
specific biomarkers or indicators that can help clinicians predict the effectiveness of combination therapy in preventing CKD in diabetes patients? Any markers which tell us that this combination of SGLT2 inhibitors and DPP4 inhibitors is
DKM1. Yes, sir. Yes, sir. Yes, sir. Yeah, definitely. Most of the biomarkers, as I've already told you in the previous slides and the discussions, right now, urine NGL, neutrophil gelatinase associated lipocalcine, and urine KIM1 kidney injury molecule 1, and serum galactin 3. These are the biomarkers and indicated in the if the GFR is less than 60, if there is a microalbuminuria less than 30 to 300, less than more than 300, macrobulimia is there, and blood pressure is less than 130/80, and glycemic control is less than 7%, body mass index. These are indicated in the
I seem to have lost you. I don't know. Are you able
GFR,
to hear me?
BSC. Yeah, yeah, you are.
Okay. So we often talk about lifestyle modifications. We know all that the lifestyle modifications are very important in CKD prevention. So the question is, what role do lifestyle modifications such as diet and exercise play in conjunction with combination therapy in comprehensive management of diabetes related CKD?
Very important, sir. A very, very useful question, as well as this is very applicable to the, because yeah, we used to nowadays every clinician is focusing on the lifestyle apart from even the medication, sir. So dietary intervention is very important in apart from having the exercises of at least 150 minutes per week. So low sodium diet, as in discussing there low protein diet is very zero point 0.8 to 1 gram per kg per day. Low phosphorus diet, if there is a, and low potassium diet if the hyperkalemia is present, and increased fiber intakes, omega-3 fatty acids supplementation is there, and Mediterranean style diet, there where the fibers are used, given to the fibers are main constituent of the diet. Exercise intervention, aerobic exercise, as said, 150 per minute per week, resistant trainings 2 to 3 times intensity interval trainings, and yoga, and it should be incorporated in our lifestyles, and regular physical activity monitoring is very important. Benefits of lifestyle is very important in improving the glycemic controls, blood pressure, weight management, enhanced renal function, reduced albuminuria, improved cardiovascular outcomes, and slowed the secondary projections. So combination therapy synergizes enhanced renal absorptions with the SGLT2 inhibitors plus diet and exercises, improve the glycemic controls with DPP4 inhibitors plus diet exercises, and blood pressure with reduction with the ACE inhibitors, ARB, and the diet exercise, reduce cardiovascular risk rate, statin with diet and exercise. These are the multiple approach, and if the clinically guidelines and clinically we guide the patients apart from all the measures, definitely we are very helpful in decreasing the hyperglycemia and the ulcer and the delaying of the CKD.
Right. You explained it really very well. So the last question is about us, the healthcare
Yeah.
professionals.
Okay.
These are times of collaborations.
Yeah, sir.
So how can healthcare professionals collaborate to provide comprehensive care for patients with diabetes and CKD? Last question. It is your choice. You can or you cannot take it. Did you get the question?
Yeah, I'm get the question, sir. It is definitely a interdisciplinary teamwork, sir. So a single person is not feasible to control all the associated parameter and all the complication of the diabetes or hyperglycemia. So it involves the primary care physicians, endocrinologists, as you are there. So very important. Nephrologists like me is there. Registration dietitian is very important, sir, because you know that we are writing the medication, we are having a lot of patients in our OPG and looking there, and we are not focusing properly on the diet. So we should have to keep a dietitian there. So, and which should be not only the dietitian, there is a diabetic educator. Now they a very popular term, diabetic educator. There have to be some certified diabetic educator must be there, and the pharmacist. but in India it is not prevalent. Usually the our compounders and the other peoples in our clinic advocate the patients. So pharmacists who can easily can educate the patients, diabetic patient. So this molecule you have to take for certain durations. Otherwise, development of the other complication of diabetes will occur. So pharmacy is very important. Nurses is very that the NP, and whatever and the social worker. So what is the role of social worker here is there? In the social worker, when a patient is go for any kind of the other test on the other doctors for other reason, they usually find that the patient is having hyperglycemia, their blood sugar is raised, but it should be for stopping. That we are now in an age of such a place. We should have to stop the development of diabetes. So screening is very important, and this is done by the social worker. Like there is many organization in the healthcare workers. So they go there and screen a simple test. They take the diabetes from the spot.
Thank you so much, Dr. Mohammed Hasnain Kaisar, for this comprehensive talk on diabetes and chronic kidney disease, or what we call in short CKD. You gave a very nice presentation on the non